Okay, everybody, we're just getting everyone on this morning. So thank you so much for everyone who's joining in. I know we had close to 80 or 90 registrants, but some folks were going to be joining and seeing the recording later. But looks like we have 30 some folks on this morning. So thank you so much for joining. On behalf of the CCSP team at the University of Colorado Cancer Center and also part of the Rady Center and Esophageal and Gastric Center of Excellence at University of Colorado. Really excited with many of our team members, as well as Dr. From our partners from Salud joining us today. So we're going to get started in here in just a sec. I will do a little bit of background about the three dynamite speakers and experts who are joining us this morning. But on behalf of CCSP team, the Colorado Cancer Screening Program at University of Colorado, I just want to say happy March as CRC Awareness Month. And I think as we continue to do our great work in cancer prevention, really thinking about our opportunities for gastric, esophageal, and GI cancers with colorectal cancers at large. So as we now enter to the last phase of the Colorectal Cancer Awareness Month, I'm excited that we are going to be starting with the top of the gastric, the gastric system with esophageal, gastric, and colon and rectal, and change it up this year a little bit, talking about the system at large. Before we transfer and really have the showcase of the esophageal, gastric, and colorectal cancer specifics as it relates to the state of the science, screening guidelines, medical management, as well as information for navigators, as those of you working in the field. We're going to be really, that's kind of the general premise for today. So we're really talking about how do we look at implementation for our primary care sites, for community-based organizations. How do we really make these connections in terms of looking at best practices for GI cancer related work and serving our communities, particularly the medically underserved. But I wanted to do a bit of a shout out because I think the last month has had some really exciting and fun things happening as we think a bit about, again, March and showcasing colorectal cancer and GI cancer work. And so for those of you who might not have seen it, Dr. Elzinga was on 9 News looking at that awareness and education around the inflatable colon. So if you haven't seen the 9 News story with Hans and his team and all of the great work with Salud as one of our primary and amazing partners with the CCSP program and is doing amazing things in cancer prevention. And Dr. Elzinga is a true leader. Check it out. Hans, thank you for all of the great promotion, the community engagement that you're doing. And I just wanted to say with Hans' BUTT, Butt Savers program, as well as many of the initiatives that Salud has been running out, a fantastic partner with CCSP over the years. And I also want to say that we've had the great honor of really working collaboratively with Dr. Wani's team and CCSP, myself and others making a formal connection around looking at the Rady Center of Excellence in the esophageal and cancer work, and really off the foundation of CCSP, and then all of the other great opportunities for cancer prevention, working with our networks. How are we really starting to think about gastric cancer and thinking about esophageal cancer as we look about prevention strategies as well as management? And how do we look at connecting patients and those of you in primary care in the community, really linking with us at CU and with many of the medical experts to really continue this capacity building. I think Dr. Wani is going to chat about this. I will share more about it. But I also just want to say that April 5th, coming up at the CU Medical Anschutz campus, there will be an amazing opportunity for a symposium where we're going to be deeper diving into some of the things you're hearing today related to the GI cancers and esophageal and gastric cancer. So if you have patients who are interested, if you are interested, if you are a community group who's interested, come be a part of this. Today is part of it. Being part of the symposium is part of it. We're going to have more opportunities for that work with the Rady Center, as well as more opportunities working with CCSP and our experts related to colon and rectal cancer. So, if you would have told me in my teens, I would be so excited about GI work. I don't think I would have ever believed you, but I got to tell you, in it to win it, love it. Let's do this together. So we have amazing speakers today. When Joe and Elsa put together a lot of the materials and we were planning this, we really thought, why not do this top to the bottom? So for our speakers today, Dr. Wani from the Rady Center in University of Colorado will be sharing perspectives related to esophageal. Dr. Bilal Mohammed will be talking about gastric cancer related to university initiatives. And Dr. Hansel Zinga will be speaking to much of the work as a medical expert for the colorectal cancer and those guidelines and work as part of the Salud Family Health Centers, as well as, I believe, Hans, now the connections also with Common Spirit. Is that correct? Yes, and I don't have my talking points in front of me.
Yeah, we do stuff with Common Spirit as well at Long Ridge.
Right. Right. So, but anyway, I want to just say today is really about utilizing the resources, tools, work at the University of Colorado Cancer Center, School of Public Health, but also many of our partners who are doing this work as well. So with that, I want to say a huge thank you to the leadership from the CCSP team, Elsa Staples, as well as Joe Henning, who've been amazing in this work as well. I'm going to stop sharing and then have Dr. Wani bring up his slides. And just a quick reminder, everyone, we will be using the chat feature today. Real-time questions, bring it. We will have discussion after as well. But we will make sure to really keep these presentations tight with about 15 minutes each on the need to know. But again, today is just one of many opportunities. So Sachin, I will turn it over to you and thank you for joining. And I'm really excited to hear more about the Rady Center as well as the esophageal work.
Perfect. Thank you so much, Andy, to you and to the entire CCSP team. To me personally, and I was talking about this with the ops team as well, having this collaboration and this partnership with CCSP has been one of the most gratifying experiences for our Rady Center that was established a few years ago now. So I'll talk a little bit about that. So thank you again for organizing this, and really excited to spend this next hour with all of you, and I look forward to your questions as well. So I'm going to use these 15 minutes to really focus on the importance of screening, surveillance, and management of Barrett's esophagus and esophageal cancer. I'll talk a little bit about where we stand with our guidelines as it relates to these three categories of screening, surveillance, and endoscopic eradication therapy, what the limitations are and what the rationale is for the work that we're doing through our center. And then I'll take a few minutes to talk to you about our Rady Center of Excellence that really focuses on esophageal and gastric disorders. So I'm going to talk a little bit about Barrett's esophagus. You may all be familiar with this term. This is a precancerous condition for esophageal adenocarcinoma. And what you can appreciate on the endoscopic image from a patient with Barrett's esophagus is that the lining of your esophagus changes when you get diagnosed with Barrett's esophagus. It is characterized by this pink or salmon-colored lining where the stratified squamous epithelium gets replaced with columnar-lined esophagus, and we make the diagnosis of Barrett's when we appreciate intestinal metaplasia or goblet cells on histology. So these are the two prerequisites to make a diagnosis of Barrett's esophagus. And the reason why we care about this condition is that it's the only identifiable premalignant condition for esophageal adenocarcinoma, a highly lethal cancer, a cancer that still continues to have a dismal 5-year survival rate of less than 20%. I want to talk a little bit about the epidemiology of this cancer, and you can appreciate from the graphs here that the incidence of esophageal adenocarcinoma has risen dramatically over the past 7 to 8 decades. You can see from the graph to the right where the incidence of esophageal adenocarcinoma has far exceeded all the other common cancers that we encounter in our clinical practice. These are just some of the estimates. Now, some of these numbers are from 2 or 3 years ago, but based on the incidence, we expect that the numbers to be far greater in 2024 and 2025. What is disturbing is that the majority of these patients actually die from esophageal cancer when they do get the diagnosis of this condition. And you can see that the 5-year survival rate is less than 20%. I can't think of too many cancers in 2025 that have such poor 5-year survival rates. Thankfully, it's not just all doom and gloom. If you look at the most recent SEER database analysis, there is some signal that maybe the incidence is plateauing. But what is really important to take away from this slide is that the majority of patients that you will encounter in your clinical practice with esophageal adenocarcinoma still present with advanced stage disease, still present with metastatic cancer. And this is what we really have to change if we are to have any impact on the epidemiology of this lethal cancer. Just a few slides on where we stand with regards to the epidemiology of esophageal cancer here in the state of Colorado. Now, again, these are data based on the analysis that was done from data available up until 2020, and you can see the age-adjusted incidence rate of Colorado and how it compares to the surrounding states. It's about 4 per 100,000 individuals. We've also been able to look at the differences in the incidence of esophageal cancer based on counties. So depending on where you practice right now, you can appreciate what the incidence of esophageal cancer is within the state of Colorado. Our mortality rate is not too different from the national average. And again, you can see how the age-adjusted mortality rate compares to all the surrounding states in our region. And the same is true for the analysis that we did as it relates to mortality in these different counties within our state of Colorado. So these data have really given us some implementation objectives in terms of ensuring that we increase awareness, offer screening strategies for esophageal cancer across the state, but also be willing and available to focus on states where the incidence rate and mortality rates are higher compared to the surrounding counties. Let's take a step back and understand how patients develop esophageal adenocarcinoma. By far, one of the most important risk factors for the development of Barrett's esophagus and esophageal cancer is chronic reflux disease. Patients who have the risk factors and have chronic reflux disease, about 7 to 8% of these individuals will develop Barrett's esophagus. This can then progress to esophageal adenocarcinoma, which occurs in a stepwise and a probabilistic fashion. The reason why I bring up this stepwise progression is that it gives us this unique opportunity to screen individuals who are at risk, identify those patients who have Barrett's esophagus, and then enroll them in surveillance programs so that we can avoid the progression to esophageal adenocarcinoma. So let's talk a little bit about what our guidelines state when it comes to screening for Barrett's and for esophageal cancer. And I would like to draw your attention to the column smack in the center of the slide. These are the most recent guidelines that we published through the American College of Gastroenterology that suggest that you should consider screening individuals who have chronic reflux disease with the presence of 3 or more additional risk factors. These include males age greater than 50, Caucasian race, central adiposity, history of smoking, and first-degree relatives with Barrett's or with esophageal cancer. Now, despite the fact that there is substantial face validity for these guidelines, I think we all recognize the limitations as it relates to screening. For one, we know what the denominator looks like, right? I mean, we know that 20% of the adult US population suffers from weekly reflux symptoms. So imagine doing upper endoscopy on all these individuals who are at risk. We also know that about 20 to 50% of our cancer patients will tell you that they've never had any reflux symptoms. And the statistic that bothers me the most is the fact that less than 10% of our patients with esophageal cancer have a prior diagnosis of Barrett's esophagus. This is despite the fact that we perform more than 2 million upper endoscopies annually for reflux in the United States. When you look at the denominator, this ranges from 20 million to 120 million individuals who are at risk for Barrett's and esophageal adenocarcinoma who are eligible for screening for these conditions. I will be sharing all these slides with you, so I'm just going to go over some high-level data. This slide just highlights the fact that less than 10% of patients who are at risk for Barrett's and esophageal cancer actually undergo a screening endoscopy. So we know that the screening rates for colon cancer are low and less than the threshold that we are aspiring to achieve. Imagine where we stand with esophageal cancer. Less than 10% of these individuals are getting screened with endoscopy at the present time. Now, the most important barrier that we learned from this study that we conducted from our primary care physicians is the fact that there's confusion regarding guidelines, not understanding who really should be screened for esophageal cancer. And of course, it's difficult to really think about all the different cancers that you need to screen for in your clinical practice. And this is what we're trying to change and make the process easier so that we can truly and easily identify those individuals who are at risk for Barrett's and esophageal cancer. This is just a case that I highlight frequently in my presentations and just highlights where we stand with screening. This was a patient of mine, a 52-year-old male, well plugged into the UC Health system, religious in terms of following up with his primary care physician for his diagnosis of diabetes, hypertension, chronic reflux disease. He had a history of smoking in the past, but did not get referred to me for screening for Barrett's or esophageal cancer until he had symptoms of dysphagia. And you don't need to be an endoscopist to appreciate the fact that this patient has advanced stage esophageal cancer. What was really sad was that when I did an endoscopic ultrasound, we found a metastatic lesion in the liver and we made a diagnosis of stage 4 esophageal cancer. So, ladies and gentlemen, this is exactly the paradigm that we need to change to really impact the epidemiology of esophageal cancer. Had this patient been referred for a screening exam, the outcomes would have been completely different from what really occurred with this patient. Here's where we can really make a difference. There's been a plethora of data describing the use of non-endoscopic screening tests that really focuses on the use of these balloons or sponges that can be administered during your primary care physician visit or when the patient comes to see us in our GI clinic. These are devices that can be administered by nurses, physician extenders, internal medicine physicians, gastroenterologists, and can actually be achieved in less than 5 minutes. Individuals at risk swallow these devices. When these devices get down to the stomach, they get deployed into a sponge or into a balloon. We pull this device out as it collects cells from the lower esophagus, and these devices are then sent to a central lab to evaluate for biomarkers biomarkers that are associated with Barrett's esophagus, and you get a binary result. If it's positive, these patients need an endoscopy. If they're negative, they don't need to undergo an endoscopy. And these are just some of the data that provided support for our current recommendations from our most recent guidelines that suggest that you can use these non-endoscopic cell collection devices as an acceptable alternative to endoscopy to screen individuals for Barrett's and for esophageal cancer. And these are just some images of one of the available cell collection devices. This device is now available for our primary care physicians and gastroenterologists here at the University of Colorado. And our goal through the Rady Center is to expand these screening strategies across the state and ensure that all individuals who are at risk can actually undergo these screening tests. And these are just some cartoons describing how these cell collection devices actually function. And think of these tests similar to other cell collection devices. Pap smear is a classic example. FIT screening is another example of how we screen for different cancers. I just want to show you an example of a patient that actually underwent screening, a 49-year-old veteran who underwent screening using one of these cell collection devices that was positive, and then the local gastroenterologist actually performed an endoscopy and identified this area that appeared abnormal, and this patient was then referred to me for endoscopic eradication therapy. And what this endoscopy video just highlights is the fact that when you bring your endoscope back from the gastroesophageal junction, again, you don't need to be an endoscopist to appreciate that what you're seeing in the 3 o'clock position just looks abnormal, should not be there in your esophagus. And we use advanced imaging techniques to really highlight the mucosal and the vascular patterns that we see. And then we performed endoscopic mucosal resection, removed the entire area that looked abnormal using this technique called multi-band mucosectomy technique. And this entire visible lesion was then resected during endoscopy, and this patient then came back for follow-up endoscopies, and we were able to then ablate his remaining Barrett's esophagus. The good news is that this patient is now free of Barrett's and with esophageal adenocarcinoma and in our surveillance programs. The diagnosis was consistent with intramucosal cancer. The case that I'm trying to make is, had this patient not been screened, you would have seen the exact same outcome of that patient that I showed you who presented with advanced stage disease. There's several other studies that we are conducting, and in the interest of time, I'm just going to let you know that once we do make a diagnosis of Barrett's, these patients then undergo surveillance. If we identify any dysplasia or early cancer, then these patients undergo endoscopic eradication therapy. Our goal for screening and surveillance is to, and let's be very clear about this, is to identify these lesions within the Barrett segment so that we can perform endoscopic eradication therapy, avoid the morbidity and mortality that is associated with esophagectomy and associated with esophageal cancer. And this slide just highlights exactly what our goals are with endoscopic eradication therapy. The candidates who are patients who are eligible for these endoscopic therapies. Lastly, our center is at the forefront of cutting-edge research that we are conducting, looking at management of patients with Barrett's, those with Barrett's-related neoplasia, and we are funded through the National Institute of Health. We've really galvanized the entire Barrett's and esophageal cancer community to answer some of these burning questions with regards to management of Barrett's and esophageal cancer. Last 20 seconds before I hand it over, our Rady Center was really established to change outcomes for patients with esophageal and gastric disorders. It's been about 2 years now that we established the center, thanks largely to the generosity and the support that we received from Paul and Katie Rady. And we've really set the stage for addressing so many issues related to esophageal and gastric centers, gastric cancers and disorders. This is the team that works tirelessly to achieve some of the milestones that we've set for our Rady Center, and I really look forward to our collaboration and answer any questions that you may have. Andy, I'm going to stop sharing and hand it over to you.
Awesome, thank you. And then we'll have Bilal go ahead and start sharing his screen. So Dr. Wani, this is fantastic, and I know we'll have time for questions as well. So for many of the people, and as we're loading up the slides for Dr. Mohammed, my question for you is, for people who are out in the community settings and people who are seeing patients, you know, there's a lot, like you noted, people who are talking about acid reflux, talking about all of these sort of things. What would be your one primary piece of advice right now as navigators, primary care folks are hearing and seeing this? Like when we think a little bit about these screening guidelines and recommendations, like your first step, like your first move out, you're hearing this work, like as a GI specialist and knowing what you know, what would be your one piece of advice for helping community and primary care activate patients into like the next sort of best piece for care and moving forward? What would that be?
Yeah, thank you so much, Andy. I think the best advice that I can give is, if we are to change outcomes related to esophageal cancer, you've got to identify the cancer early. You've got to screen individuals for Barrett's and esophageal cancer. And then when you do make the diagnosis of Barrett's, recognize that these patients need to be in surveillance programs, similar to the concept of if you have colon polyps and you remove them, these patients continue to be in surveillance programs. The best news that I can share with all of you is that not every patient needs to undergo an upper endoscopy. We have other options to screen for Barrett's and esophageal cancer, and hopefully that whole concept will make it easier for our patients and for our providers to ensure that at-risk individuals do get screened.
Awesome. Very good. Thank you for that. All right. We will move to Dr. Bilal, and we'll go forward. So Bilal, I'll hand it, or Dr. Bilal, I'll hand it to you.
Thank you so much, Andy. Truly an honor and privilege to be here. And as I always say, because Dr. Wani is our esophageal, cancer expert, it's always a tough act to follow, and unfortunately, I'm always following him. So, we're gonna switch gears and talk about another cancer, which is in the GI tract, which is a gastric cancer. So, why is it really important to talk about gastric cancer? Until about a decade ago, the gastric cancer was thought of more of a disease of the East and not as much of an issue in the West and North America. But it is the third leading cause of cancer-related mortality globally, and there has been an increasing incidence of gastric cancer. This is data from the SEER database, which actually shows that, in 2019, there were more gastric cancer cases in the U.S. As compared to esophageal cancer cases. So definitely, this is up on the rise and becoming an issue for our patients as well. The challenge with gastric cancer is that, like I said, that we always thought it is a disease of the East, is that the patient population that it affects are typically patients from Asia, Korean Americans, Vietnamese, Japanese American people. And if you look at this really nice study that came out in Gastro in 2020, this is the cardiac gastric cancer, which is sometimes coming from the G junction or related to esophageal cancer that Dr. Wani pointed out, and non-cardiac gastric cancer, which happens anywhere beyond that in the proper stomach. You can see that the incidence of gastric cancer in non-Hispanic whites as compared to other Asian races. So in Korean Americans is 13.3 times higher in Vietnamese Americans, 6.6 times higher than in non-Hispanic whites. So certainly an issue, and we have now increased population of immigrants, and not just immigrants, but their subsequent generations are increasing in incidence and in prevalence in the United States. So this is a slide which shows the US 2020 census. So if you look at the US 2020 census, you can see here that 56% of the patient population is white, and all the other races or ethnicities are divided. But why is gastric cancer, why are we talking about it here today? This is the projected census from 2045 that we expect the population to be if the growth trends stay continuous. And if you look and see here, the non-Hispanic whites are actually going to be a minority. They're going to be 49% of the population. And if you look, the Asian population is 7.9%. The Hispanic population is going to be almost 25%. So a quarter of patients people in the U.S. are likely to be Hispanic over the next 2 decades, which is an alarming sign because this means that gastric cancer is going to continue to rise more. So this is why the topic of gastric cancer screening is becoming more and more relevant. So, the challenge right now is that as of today, there's a lot of confusion and not a clear pathway on gastric cancer screening. We don't know who to screen. Clearly, we don't know when to screen, and we don't know how to screen. So my hope is by the end of this discussion today, we'll at least have some idea of where we are today, but more importantly, where we're going over the next decade. So goal of any screening program is primary prevention and secondary prevention of gastric cancer. What we do know is one of the risk factors for gastric cancer is H. pylori infection, which is one of the few infections that are pre-malignant and can predispose us to cancer. So obviously in people who have high risk for developing H. pylori, testing and eradication is primary prevention, and then where the universal screening comes into place is secondary prevention. What are we trying to accomplish by screening is kind of similar to what Dr. Wani pointed out, is trying to find early gastric cancer. So this is a very alarming statistics in this paper that came in Clinical Gastrohepatology in 2022, which if you look at it, that basically what proportion of patients in South Korea, Japan, and US were diagnosed with an early stage of gastric cancer. So South Korea and Japan have formalized gastric cancer screening pathways, and you can see that almost 50% of patients diagnosed in South Korea and Japan were diagnosed at an early stage. Whereas in the United States, only 1/4 of patients are diagnosed at an early stage. And this is even more important because if you look at the 5-year survival of gastric cancer in the United States, it's only 32%. Whereas in South Korea and Japan, where there's formal gastric cancer screening programs, the 5-year survival is 60%. So really, finding GI tract cancers, you'll see the theme for today is that finding early GI tract cancers early can really help improve outcomes. But then the question is, why aren't we screening? Because obviously, we discussed that gastric cancer, the populations that affect gastric cancer are variable. So what is the cost effectiveness of screening? So this is a Markov model study out of New York, where they basically looked at all 50-year-old Asian Americans. And the reason for having a 50-year-old age cutoff at that point was that is when we used to recommend colorectal cancer screening was at age 50. So they're already coming in to get an endoscopy. So they looked at patients in 3 groups, and if they were to get an EGD along with a screening colonoscopy with biopsies, and if the biopsies showed gastric intestinal metaplasia, which is similar to Barrett's esophagus in the esophagus, is that it's a pre-malignant condition, do surveillance biopsies every 3 years, versus group 2, where they do an endoscopy and biopsies every 2 years, no matter what the pathology showed, and no screening. So what did the study show? That actually, compared with performing no endoscopy, performing a one-time upper endoscopy in this patient population with biopsies, with continued surveillance, if gastrointestinal metaplasia was identified, was cost effective. So certainly, because the cost and the amount of dollars we spend on treating late stage gastric cancer is much more effective in a select patient population. This is an article that we published a couple years ago on gastric intestinal metaplasia. So basically, like I mentioned, it is a precancerous lesion for a gastric cancer. So it's a pre-malignant condition. And then once you find intestinal metaplasia, the challenge was until a few years ago, we didn't really understand what patients were high risk. So now we know from some of the studies, especially from the East, on risk stratifying gastric intestinal metaplasia. So gastric intestinal metaplasia can be diffuse versus local. Obviously, as it probably seems very simple, like if it's diffuse, it's more if it's spread to the antrum as well as in the body of the stomach, then it's higher risk. If it's incomplete versus complete, so incomplete is higher risk. And obviously, patients with family history, with first-degree relatives of gastric cancer, we always ask our patients in the clinic if they have a family history of colon cancer. But now it's important to ask them if they have family history of esophageal cancer, family history of gastric cancer, family history of GI cancers, because those patients are at higher risk of developing, and we could catch those patients early. Again, the reason this is important is because this gastric cancer does not happen overnight. This chorea cascade, which was initially presented in 2007 by Dr. Correa, goes over how this occurs. So you have normal stomach, and H. pylori or other environmental triggers can lead to non-atrophic gastritis, which then over time can lead to intestinal metaplasia, which can convert incomplete intestinal metaplasia, which then can lead to dysplasia, similar to the esophagus, and then dysplasia leads to adenocarcinoma. So our hope is that we are catching this group somehow early enough to where we can intervene, and we'll talk about that here in a second. And interestingly, Dr. Wani had a patient who actually followed the entire chorea cascade yesterday that we reviewed in detail, so kind of highlight that these patients are out there. So this shows the risk of gastric progression of gastric cancer in all these patient subtypes. And as you can see that as the chorea cascade advances, the annual incidence and risk of gastric cancer, especially when they have high-grade dysplasia, is almost 6%, annual incidence. So what do we do is it's obviously hard because these are very subtle features and not always easy to find on upper endoscopy. We don't have a non-invasive test as of yet. So we rely on endoscopy, and endoscopy, like any procedure, is operator dependent. So one of the ways to limit that is to do biopsies. And this is a Sydney protocol of biopsies that basically is what we call as mapping biopsies to see the extent of gastric intestinal metaplasia. So here you can see either we have biopsies and we take biopsies from the antrum. This is the incisor angularis of the stomach for those who are not gastroenterologists here. And this is the body of the stomach. So we take 5 different areas of biopsy in the stomach spread around, and we try to see if we can identify diffuse metaplasia or early dysplasia. So what that has pushed in is developing of quality indicators of upper endoscopy. Because when I was a fellow, we would always say that like how quickly can you do an upper endoscopy, but now we're starting to realize that it's not just doing an endoscopy, not just looking for big masses and tumors, but trying to find these precancerous lesions. So this is actually hot off the press that came out this year from one of our GI societies, which basically shows how important it is to have photo documentation during upper endoscopy. And when we do an upper endoscopy, you could have blood, you could have food, you could have debris, you could have secretions. So if you look at all these pictures, these are pristine. So our goal at endoscopy is to clean as much as we can to make sure that we're able to visualize all these things. We take pictures, we take biopsies, and take a look at this area. So really starting to find these lesions. So what do we know? What are our guidelines would tell us about gastric cancer screening? So the British Society of Gastroenterology came up with guidelines which talk about similar things we talk about is you do Sydney biopsy protocols to try to map your gastrointestinal metaplasia, and whether it's extensive or distal, as we discussed, differs it to be a low risk or high risk. And then high risk patients should get a 3-year surveillance, high quality endoscopy with narrowband imaging and image enhancement. And patients who are in low risk don't need to be continuous surveillance. Our GI organization, the AGA, also has recommendations on this. The fact that we're putting out recommendations alludes to the fact that we're talking about it. Well, the evidence may not be there as of today, but this tells you that this is a concerning topic, and over the next decade, we're going to hear a lot more about it. And the time to start working on this is soon. So the AG also recommends same thing, but do consider that patients who are at higher risk for gastric cancer. So those are racial and ethnic minorities, Hispanics, blacks, as well as Asians we talked about, and immigrants from high incidence regions and their non-immigrant children are still at high risk for gastric cancer. So do we screen when we feel like we can do something with it? So if we can find these precancerous lesions, which is again similar in the esophagus, is this where dysplasia starts occurring and we catch it early. We have a lot of different endoscopic tools available. These are the British Society guidelines, which talk about what happens when you see visible high or low grade dysplasia, and they recommend if it's less than 1 centimeter, we do a mucosal resection. If it's greater than 1 centimeter, we have more advanced resection techniques like an ESD, which is recommended for all lesions with dysplasia greater than 1 centimeter in the stomach. These are our American Society guidelines that came out last year, which talk about early gastric cancer and how you treat it. So the goal is to find early gastric cancer, and what happens if we find it? We have minimally invasive treatment options to treat them through endoscopy. Obviously, surgery still stays a critical part of management, but if you can do organ preserving procedures, then it becomes really critical. So here you can see that if you have early gastric cancer, less than 2 centimeter, you can do EMR or ESD. And if you have a gastric cancer that's more 2 to 3 centimeter with more poor differentiation or moderate to well differentiation advanced differentiation, then you can do ESD. And obviously, if you have poor differentiation, then surgery is still the treatment of choice. And this is literally last week, the third GI organization has now also put out guidelines for pre-malignant conditions. And again, sort of reinforcing how important this is. And again, one of the things, the theme that go in is that you are having a patient who has no family history, a patient who's white versus a patient who's coming from a high risk or ethnicity or coming from high incidence of gastric immigrant population as they're increasing. Those are different patients, and we should be having a conversation of screening those patients and then trying to risk stratify if they have gastric intestinal metaplasia and then put them on screening programs. So of course, what important here is here, as you can see, a patient that was referred to me with a community doctor who found dysplasia in the stomach. Patient had background of atrophic gastritis intestinal metaplasia. So I'm going to do a full thickness resection of this because biopsies are only superficial, and we already know this is a high-risk patient from a Hispanic background. So this is a procedure where we can go all the way through to the muscle layer. So here I'm just going to grasp the tissue, and we usually pull it back into a cap, which is a preloaded clip in there. And once this is in the clip, you can see here, we'll deploy the clip and then we resect. So even though we're cutting through all the layers of the GI tract, which would be considered a perforation many years ago, this is not exposed because the peritoneum is never exposed. So this is called non-exposed full thickness resection. And here you'll see that I go back in and it's we've resected the tumor. The cirrhosis has never been exposed, an outpatient procedure. This potentially lesion that could have become a cancer in a couple of years is out. This is a pathology that shows negative margins. You can here see the ulcerated mass in the corner over here, and the patient is preserved from a surgery, and more importantly, preserved from older mortality. This is actually an early gastric cancer that came through us from our multidisciplinary clinic over here at University of Colorado a couple of weeks ago. And you can see it was an advanced gastric cancer, but caught it in an early stage with higher risk features. So here we're doing what we call as ESD procedure. One of the limitations we have as compared to surgeons is that we only have a scope in one hand and the other hand is operating the scope. So this is where we're using traction to allow us to get underneath the tumor. And this tumor was actually pretty invasive and scarred, as you'll see as compared to the other one. And you can see here this tumor is removed. This is the tumor here in the middle. We've got really good margins on the side. And again, patient stayed overnight because of some issues and then went home the next day. So much more, less morbidity than surgery. So the point is, if you can catch this early, we can do something about it and prevent the morbidity and mortality associated with gastric cancer. So thank you so much again for having me, and look forward to question and answers.
Awesome. Thank you, Dr. Bilal. And in the interest of time, everyone, I know there's some texts that are some chats that are coming through, and so we'll answer those real time. I am going to go ahead and queue up Dr. Elzinga. And everyone, I apologize because we did have a little technical assistance. You have technical assistance, but we had technical difficulties as well this morning. And so we were running a little late. So if everyone can stay on with us for an extra like 5 or 10 minutes this morning, cool. If not, totally get it. We can do some follow-up with Q&A as they come in too. But Hans, we'll go ahead and have you queue up your slides. And excellent. I know that we haven't heard a ton about esophageal and also for gastric cancer, so today has been great. Hans, are you able to throw up your slides here? Awesome. And we'll have Dr. Elzinga talk about colorectal cancer. And then Sachin and Mohammed, I think in the chat, if we want to also add information about, there's questions, I think that as we're talking about the three of these, essentially, what are we talking about for the trifecta, right? What is the incidence? What is the risk factors? How do all of these fit, right? Because I think we hear from Hans, we hear from all of you that, sometimes people are getting workups for uppers. And then if it's not an upper, then what's going on with the lower, and then the lower to the upper. And I think as we started today, this is really a system. And when we talk about the GI system and GI tract. So I'll have people share perspective in the chat. And Dr. Elzinga, I will punt to you for taking us home. So go ahead, Hans.
All right. Thanks so much. And thanks for two excellent lectures. Those were both great. I've gotten to collaborate with Dr. Wani on multiple patients, including for dysplastic Barrett's, and look forward to working with Dr. Bilal. That's just awesome. Those are really interesting lectures. And I get to try and follow that, which luckily it was my AV issues that caused us to be delayed. So it makes sense. I'll just go quick here as best I can. So I'm a family medicine doctor up in Longmont. I work at Salud Family Health. It's a federally qualified health center. We actually have an endoscopy suite within our clinic, and also work at Longmont United Hospital, which is a common spirit facility. So we do, but in our total program, about 1,500 endoscopic procedures a year. I do about 1,000, which is unusual for family medicine doctors, but we have a very high risk population as far as for accessing care, and then also high risk for a number of these cancers that we've already been talking about. So what I'm going to talk about briefly are some colorectal cancer statistics, the new guidelines that came out. They're not new, really, 2021. Some brief review of colorectal cancer screening modalities. We'll talk a little bit about some screening disparities, challenges, and opportunities. I'll go very briefly over the ACG guidelines for high-risk populations. I think that's important for our patient navigators, just to know a little bit about that. There's some controversial recent literature that patients may have read about that I think is important to discuss. And then I think a really important topic is, can we all be colonoscopy salespersons? I think that this is a part of patient navigation that's important, because you get asked those kind of questions. Is this a worthwhile test? I don't think colonoscopies sell themselves. I think we have to do it. So how important is colorectal cancer? The answer obviously is extremely important. The number 2 cancer killer overall. If you're a non-smoker, it is the number 1 cause of cancer death. The lifetime risk, incredibly high, 1 in 24 for men, 1 in 26 for women. Risk of dying from it, 1 in 57, over 50,000 new cases likely in 2025, and over 50,000 deaths from colorectal cancer in 2025, and over 150,000 new cases in the United States. So the big trend, and this is a trend that caused these changes, is an increased risk of colorectal cancer in young people. So in this 40 to 49-year-old age group, about a 15% increase in 15 years. This is a number that I use with patients, which is incredible, that if you're born in 1990, you have over a 4 times increased risk of developing colorectal cancer compared to somebody born in 1950. Right now, it looks like in this age group, the increase is about 2.5% per year. Overall, this is an illness of older people, but yet 20% of new colorectal cancer cases are happening in people under 55. And this statistic, I think, is really alarming, that only a third of the patients diagnosed before age 50 have a family history or have known genetic increased risk. So you can see this trend overall. Incidence has been decreasing, mortality has been decreasing. We think that there's a combination of screening has helped as well as new treatments. But the group that really is not following these trends are these younger people. So you can see the increase in incidence, you can see the increase in mortality compared to the 50 to 64-year-olds where it's gone down, although there's an indication that that may be starting to rise again, unfortunately. And then you can see the over 65s who are doing well. And this statistic that the number one cause of cancer death in those less than 50 for men is colorectal cancer, number 2 for women, breast is number 1 for the under 50s, but that's just an incredible number. So out of this came this new recommendation in 2021 to switch to 45 instead of 50. There was a lot of discussion as to how effective that would be because colorectal cancer is still relatively uncommon in that age group, and that's why it is a B recommendation. So an A recommendation are the ones that have the most benefit, and that is the 50 to 75. In those over 75, it is a C benefit, but this does not apply to those who have not been previously screened. So I think this is really important that you know, if you have somebody who's over 75, never been screened, they should still be screened. They actually have a significantly improved benefit, but to continue screening in people who have not had polyps doesn't have that same benefit. And then, yeah, that B recommendation for 45 to 49. So how do we screen? What's the best test? So the tests that were recommended are the high sensitivity based stool tests. So these are the FIT tests performed usually once every 1 year, but there are some competing recommendations that say sometimes every 2. The FIT plus abnormal DNA, that's the Cologuard test, is once every 3 years. As far as what's being covered, it probably is a better test if done once every year, but you can see the cost of it. There are lower sensitivities, lower specificities. Cost is much lower. FIT, less than $25. You can see how much the Cologuards are. These probably lower mortality by about 40% for the yearly FIT and by about 50% for every 3-year Cologuard. If you look at colonoscopies performed once every 10 years, you can see there's increased risk. Cost is significantly greater. There are facilities in the state of Colorado now that are charging $10,000 for colonoscopies. So it is definitely an increased cost. It can actually prevent colon cancer, which is the thing that we love about it. By finding polyps, removing precancerous lesions, we can significantly lower the risk of developing colorectal cancer, as well as finding colon cancer early. If we find early stage colorectal cancer, the 5-year survival rates are over 90%. So it makes a huge difference. CT colonography, very expensive, not as sensitive for sessile polyps. And I think now that Medicare is actually not choosing to cover these, though this was recommended by USPSTF, FlexSig's not as commonly done anymore. Patients don't really like them, although the cost is significantly less. These recommendations do not include blood tests like septin 9, urine capsule endoscopy. Barium enema is no longer recommended. The older FIT or older stool-based tests, the guaiacs, that were not able to detect the difference between human and animal hemoglobin, no longer recommended. Insurance and cost issues. So these are huge, especially when you're dealing with patient navigation. So Medicare basically follows USPSTF recommendations. They began covering screening colonoscopies in 1998. There are actually special codes that we use, G codes, for screening for average risk, high risk individuals. There are things we need to do for incomplete procedures so that people can have a repeat colonoscopy if they have, for example, an inadequate prep and still have it covered. Polypectomies are a complex issue on screening procedures as far as how Medicare likes to cover them. These are important issues for patients as far as paying for these and make a big difference as far as people's actually access to these procedures. Medicaid doesn't make any specific intervals for these things. Private insurance, asymptomatic versus symptomatic makes a huge difference in what patients actually have to pay. Positive fits used to be a very difficult issue because they would be considered diagnostic, and this would include positive Cologuards as well. They are now considered to be part of the screening process and should be covered, but I still encounter patients who have difficulties with this. Uninsured, a huge issue. This is what we're really dedicated to at Salud. Pathology fees can be a surprise, and sometimes very significant cost to patients that they're not anticipating. Anesthesia, if procedures are done with monitored anesthesia care or propofol, that can be a bill that can be very significant in the $500 to $1,000 range. So who does these apply to? Average risk asymptomatic individuals, regardless of risk factors, although they do recognize that Black individuals do have higher risks. They looked at some screening benefits, and they did this perfect adherence model, which showed these incredibly small numbers that are needed in order to prevent a case of colorectal cancer and prevent a death from colorectal cancer. Only 44 patients screened to prevent a death. So that's from 50 to 75. You need to screen many more if it's 45 to 75. But I think one of the lessons here is that this is done perfectly, and doing it as best we can is really important. So what is our really challenges and opportunities right now? We've lowered the numbers. That's 20 million more Americans who now require screening between the ages of 45 to 49. Right now, only about 20% have been screened in that age group. There's talk about lowering this maybe further to 40, because there's not like a hard cutoff at 45. It really is this whole decade of 40 to 50, maybe yearly fit testing. If we screen this group, we may have less of a benefit because it's less common. If we target underserved populations, we may be able to increase this. So who are these populations? Black race is a huge difference here. Earlier onset, also higher risk of dying from colorectal cancer. 1 in 41 Black males will die from colorectal cancer. That is an unbelievably high number. Hispanic, less than 20% of uninsured Hispanics are receiving screening, and this increase has been on the realm of 45% increase in that 40 to 49-year-old age group as far as the incidence of colorectal cancer. Underserved populations in rural areas, less likely to get screened, and they've had a 35% increase in that 40 to 49-year-old age group. I put in here what to do for these higher risk individuals. So these are the folks who have a family history. It also, one of the things that I think is important to note here, if you have one first degree relative less than 60 years old, you have approximately 2 times increased risk of developing colorectal cancer. Remember those numbers for before. That roughly is a 1 in 12, 1 in 13 lifetime risk of developing colorectal cancer. It's really important that we get them not only initially screened, but provide a decreased interval, so once every 5 years for follow-ups, or even sooner, depending on if they have polyps. So this came out in 2022. This was a large study done primarily in Poland, but also Norway and Sweden, and it did not show the kind of improvements that we were hoping in not only decreasing colorectal cancer incidence, but in decreasing colorectal cancer death. And this got a lot of publicity, but I think it's important to know there were some significant limitations here. And one of the really important ones was that a lot of people did not participate. So we know that just sending people an invitation to screening doesn't really work. Low adenoma detection rates do not prevent cancer well. And that was a problem within the study, that they were not necessarily receiving high quality colonoscopies. And there were per protocol analyses that looked at what the actual improvements might be. These are definitely not the ideal way to look at studies, but they showed significant improvements that would be more in lines with what we actually think would be expected. Overall, it seems like a relatively large study, but the numbers that we do in our program are actually greater than the overall numbers that were done in this study, and we're seeing better numbers than that. And I think the main reason is because of quality. And these are the parts that I think are really important for navigators. So one, on the side of the endoscopist, we need to have high adenoma detection rates. Amazingly, last year was the first year that I was over 50%. I was 56%. We're doing colonoscopies on younger people. I should be having a lower adenoma detection rate, and yet it's going up. And you can see that incredible decrease. So every 1% increase is a 3% decrease in colorectal cancer incidence. So we need to do a really good job of finding polyps and removing them. And one of the things that really helps is an adequate bowel prep. And that really is a part of patient navigation that's incredibly important. So we need to have a really good colon to be able to, a really clean colon to be able to look at. So all of that patient education around bowel preps and diet beforehand and all those things is extremely important. And there's not one best bowel prep. It really is individual, but that education piece is huge. Some of these other things, as far as how we do things, are more related to the endoscopist side. But I think the quality of these things, like we were talking about, it is very operator dependent. We need, as endoscopists, to make sure that we're doing extremely high quality procedures. And I just wanted to include a couple of quick pictures in order that you could maybe see some of these things in practice as far as what we see and how those things make a difference. So this is the very end of the colon. That's the ileocecal valve. And this was a 50-year-old who was having a screening procedure. And if you just looked at this quickly, it looks like the cecum's there. You might almost convince yourself that you're seeing maybe the opening of the appendiceal orifice. But what's interesting, as I waited longer and actually insufflated better, a polyp just popped out of where the appendiceal orifice would be. And this is a good sized polyp. So if you look here, this is after doing a lift and then using a snare in order to do the measurement. That's a centimeter across. So this is close to a 2 centimeter polyp. We use a lift in order that we don't cause damage using electrocautery, because this actually turned out it was actually pedunculated, so on a stock. And you can see afterwards when we removed it, there's actually a little bit of cautery effect here. So using that lift helps to improve patient safety, which I'll talk a little bit about because I think that's a question that gets asked as far as, is this a safe test? And interestingly, we then, because we deal with a population where they're coming to get procedures from a distance, we put a clip on to help avoid or decrease the chance of a post-polypectomy bleed, which is another important possible risk of the procedure. This was a polyp with high-grade dysplasia, very similar to what Dr. Wani was talking about, where there's actually cancer there or cells that are very similar to it, limited to more surface parts of the tissue, so that, yeah, this was removed completely, and the patient avoids having a colon cancer and avoids a surgery. So the harms of colonoscopy, overall, it's a very safe test. Our numbers are much better than the ones that were in this journal article. The numbers that were in the Nordic trial were actually relatively similar to that as well. I included these references as far as those papers that I think were most important. And I think a resource for everybody to consider using, especially with patients, is cancer.org/colon, which has excellent resources both for providers and for patients. And then the last thing I wanted to say is just basically being a colonoscopy salesperson. So as a disclosure, I was the salesman of the month for the Dallas Morning News in 1989 as a telemarketer. And so I definitely understand something about sales, and you have to do a really good job. And I think it's basically motivational interviewing. And I think even at the level of patient navigation, talking to patients, you're an important part of their getting these procedures done. So not only the education around how you get the procedure done, how you prep for it, what to expect, but you're an important part of their understanding it and understanding how important these procedures are. They're a procedure that a lot of people are afraid of for very obvious reasons. The more that we can do to educate patients and improve their understanding of how they get these procedures done, I think the better we can all do at preventing colon cancer and decreasing colorectal cancer mortality. So thank you so much. Hopefully I got that in relatively in the time period. I tried to hurry it along as much as I could, but it's a big topic.
It is a big topic, and that's what you get for being at the end of the GI track. But I will say we've talked a lot about colon and rectal cancer through the years, and Hans, this is amazing. I have an entire list of amazing factoids about Hans that I have. And this Dallas Morning News, like innovator or salesperson of the year. Oh, I'm going to just weave that in, Hans, to all of our amazing tidbits of info. Everyone, I know we are at time and we're a bit over. So thanks everyone for the great patience this morning as we had technical issues. Esophageal and gastric cancer symposium. If this really is your jam, please join us April 5th. We will continue to actually work with Dr. Elzinga, many of our partners all throughout the state, to feature and to talk. Elsa, Joe, I know there were the questions, and I think Dr. Wani had talked about there really many of the factors related to Hans, I think you can speak to this too, and I think Sasha did this in the chat. But really, when we talk a lot about exposures, right, a lot of the risk factors, we also know that really in terms of people's activities, how they're living, weight gain, really healthy diet, eating lifestyles, a number of these things really do have for all cancer and for GI cancer specific. But I think, Hans, as we close out in terms of this idea of, kind of this, because, you do a lot of the management, right, of not just lower, but even upper and the like. So, I mean, if you could kind of take us home, and I don't see any other specific questions here, but really like how all three systems work, Hans, and if Dr. Bilal's still on to, have a safe, but I'll just have you, like, what would you say about all three cancers and really the prevention, Hans, as a clinical provider and someone who refers?
So thanks so much for organizing this, Andy, and thanks so much for CCSP. We've had a really awesome relationship with you all since its inception back in 2006, so amazingly, almost 20 years. So the thing that I would say as most on this, and I think Dr. Bilal and Dr. Wani are more experts on some of the upper stuff, certainly than I am, but one of the facts that I think is extremely interesting about colorectal cancer in particular, and this is shared with the upper GI tract cancers as well, is that about 50% of colorectal cancers are likely preventable through lifestyle changes. So not smoking, healthy diet, avoiding processed foods, excessive alcohol consumption, keeping a healthy weight, all of the things. It's estimated that could decrease or it could prevent half of colorectal cancers, which is just an incredible number. And I don't know if Dr. Bilal or Dr. Wani have something to add to those numbers for uppers.
No, I think go ahead, Dr. Wani. I think
No, please go ahead.
No, I was going to say the same thing. I mean, I think that, Dr. Wani put in the chat. I mean, I think smoking is a huge risk factor. Alcohol use is a huge risk factor for upper GI tract malignancies. Obesity is another big risk factor. So all those things that you mentioned, oftentimes patients will ask me like, hey, what can I avoid? And I'm like, all those things that are bad for you, that generally should be avoided, like processed foods, healthy lifestyle, exercise, avoiding all these things. No doctor will ever tell you smoking is good for you. That's just all my answer to every single time when I remove large colon polyps. Patients always ask me, and I give them the same exact thing as you said. So,
the only thing I'd like to add is, and I mentioned this in my chat, recognize that population-based screening, general population screening for colorectal cancer is recommended. Screening for upper GI cancers, esophageal and gastric, is a little more nuanced than colorectal cancer screening, where you recommend this screening for all comers, right? But when it comes to esophageal and gastric cancer screening, you really have to think about the risk factors involved. And my humble suggestion to you would be that when you are recommending colorectal cancer screening, just think, does your patient merit screening for esophageal and gastric cancer or not? And if you have any questions, always reaching out to your GI friends, I think, would always be helpful. We're trying to change this and make it a little easier, where we will be using prompts or using your electronic health records systems, where you get a prompt to tell you, okay, your patient should be screened for colon cancer, but your patient should also be screened for esophageal cancer given all these risk factors. So just something to think about when you order that test.
Great. Okay. Any other questions, thoughts? I think I saw one person come on camera when we were chatting. And Dr. Dunnington, I don't want to put you on the spot, but I did see some questions from you and I see your face. And yes, you were voluntold into a question. But sir, do you have any comments or questions or thoughts?
Well, the main question is, if we were in a perfect health system that actually paid for healthcare for everybody, are there enough endoscopists to do all these screenings? Just like, are there enough radiologists to do all the lung cancer screenings?
Yeah, I think I can take a crack at this. It's because we've really thought about this a lot, and we think about this on a regular basis. I think the approach that we are suggesting, especially using these non-endoscopic screening strategies, I truly believe that we can handle the screening procedures that need to be done if done in the right population. If we focus our efforts on those individuals who really need these endoscopies, I think we can make a difference because there's ample data suggesting overutilization of endoscopies in patients who really don't merit a procedure. Using these non-endoscopic cell collection devices, we will truly be able to identify those individuals who are at risk and merit an upper endoscopy. So I'm not entirely sure if we'll be at a point where we have enough individuals that can do an endoscopy tomorrow for a patient who has a positive test, but I think using this risk stratification approach, we can ensure that those individuals at risk get their endoscopy and avoid overutilization of endoscopy at the same time. So that's my sort of quick response, but I'd love to hear what Bilal and Hans have to say as well.
No, I think you're 100% right. I mean, I think especially in colon cancer, we've made a lot of progress in that regard, especially with non-invasive testing. The U.S. Multi-Society Task Force now recommends that FIT is actually a tier one test in it, just as equally good as colonoscopy, as long as it's done annually. There's others, fecal FIT DNA test and things like that. And there's just earlier this year, New England Journal of Medicine, the first blood-based test initial trial came out. I mean, of course, we're not ready for prime time yet, but I think we're eventually going there. So certainly, I think that the push for non-invasive testing is there for that reason. But the challenge is that right now we're not even getting all the people to screening who need screening. So the classic thing that's always said about screening tests is the best test is the one that gets done. So if there is a patient who will just get a colonoscopy done, that's great. If a patient will get a FIT done, it is important to just get them some degree of screening because the impact is significant.
Mhm.
Yeah, I think that's all really true. And certainly, what we see is that, yeah, access for certain underserved populations is very difficult. And, that's what we do at Salute. And it's a problem that there's, pockets where access is easy and there are pockets where access is very difficult. And having those numbers for the patients where they need them is a difficult thing when we don't really have a cohesive health system across not only our state but nationwide. And I think some of those differences we'll see going forward how those come together. But yeah, it makes it difficult to get everyone screened at those levels where we need. And I highlighted some of those in my talk where, I mean, it's incredible that uninsured Hispanics less than 20% screened nationwide. That's abysmal. We need to do better.
Right. And I do think that as you're all speaking, we've talked about, the different types of non-invasive tests. I know that's definitely true for the esophageal, talking about that for colorectal. We're seeing, starting to see more emergence with even blood tests and really looking at that. So I think that point around capacity and utilizing the types of tests that we do have that show great evidence and that will be emerging will be key. The one thing I do also want to highlight though is also, I think, especially for colon and rectal, the number of people who have family histories or signs and symptoms, and really thinking about this, utilizing colonoscopy for the increased and high risk individuals. And I think, Hans, as you had talked about, knowing your risk is a really big deal right now. I think even in the under 50 crowd, right, if we did a better job of recognizing symptoms, patients reporting symptoms, folks being worked up, everyone getting exams on time, right? As well as like thinking about genetic and hereditary syndromes like Lynch, or even a family history. If we utilize the capacity we do have, for those individuals, right, we could markedly decrease the number of people who have incidence and mortality in the very young right now too. So, you know, a lot of really amazing opportunity. But I want to close out by saying, and have each one of our speakers, if they want to say anything else in closing. I think we've commented on all of our, you know, kind of the key pieces in the comments. But again, I think, Hans, you know, I heard you talk about, you know, for the lower, we were getting ready to put in a grant application, right? And you're like, hey, Andy, like, hey, like we do so much for the colon, you know, can we add more work up for the upper endoscopy, and thinking about the screening opportunities and those pieces. And so I just want to say, in the spirit of that, and I know working with Dr. Wani's team now, I know that that is the idea of collaboration. Today is about that work, bringing people in from CBOs, from the primary care, from our communities, and with our larger health systems that can help with this work. That is the name of the game. And I know all three people on this call today who are featured as our SMEs, as well as people who are coming on, you know, that is really the spirit. So I'm hoping that it reminds me of Church Lady on SNL every time I say spirit. But what I'm thinking is that as we do more of this work together, I do think we want to talk a lot about, I think, like even the questions today about how are we synergizing to really provide these great opportunities where we're not just thinking about an isolated disease state, where there's opportunities for prevention, early detection, management, and getting resources out to all of you. So Dr. Wani, final comment and thought.
I just want to say thank you, Andy, to you and to your entire team for bringing this entire group together. And I want to thank all of you to be a part of, for being a part of this discussion. I think it is this collaboration between all our different departments, divisions, sections. No matter where we practice, I think we have one goal, which is to impact positively outcomes that are related to GI cancer. So really looking forward to this collaboration moving forward. And we're always here if you have any questions on any of your patients with any GI disorders. So again, thank you.
Awesome. Bilal?
No, just echo everything Dr. Wani said. I mean, you know, I always feel like we're subspecialists do only a little bit of the work, and all the real, you know, work for preventing and screening really comes from our primary care physicians, and you know, take care of the front line and the quarterbacks for everything. So we're always available. If you ever have questions, if you're ever in doubt, you know, message, email, text, call for anything that you have. And you know, if you have, we're always happy to get talk about your patients, whether we see them or not. So thank you for all you do, and look forward to continued collaborations.
Awesome. Thank you. And Hans, one final comment, and we will close for today.
Yeah, thanks so much to everybody. I think getting the word out on these things is huge. And especially, yeah, to the navigators, what you do is invaluable to help patients, and it makes a huge difference in helping prevent cancers, you know, not just of the GI tract, but elsewhere. And so, yeah, really appreciate your attention to all of these issues. They make a huge difference for our patients. And
Awesome.
thank
Very
you.
cool. And I do see the note. I just want to also remind everyone, I think we are up against it as it relates to NIH, NCI, CDC, DOD, all the cuts, right? As much as most of us can talk within our community about the impact of the work we're talking today, I think those of you on the ground have more influence than you realize with your legislators, with your community. So please, everybody, as much as you can talk about the responsible and good science that's happening. And the other thing I just want to mention, we did spend some time at the Capitol this week with Dr. Wani and several of us talking with our legislators, senators. Our programs got some shout out, right? But I do want to say one of the cuts that come up, and I really do feel badly for a number of people who are trying to make decisions in this really strange time and with budget cuts. The Medicaid reimbursement for navigation and community health work is one that's been noted on the chopping block. And so one of the things we're hoping is that all of you who are building this capacity for those who are not licensed individuals, those of you who are navigating in the workforce, who are licensed, we are doing our best to make sure that we continue to put funding out in the community to do this kind of work. So I've been working this morning till late last night. It looks like the GBC is going to continue on with drafting language to repeal funding for CHWs with Medicaid dollars. I think these sort of things are happening in discussion with CMS at the federal level. So as we send out more alerts about how to really share the value, the work, if you're asked to testify, please, everyone, just come in, and all we can do is speak from our hearts. I think we can talk about the impact in our communities, but it goes further than we think. And so thank all of you for being good stewards of the money, the work, the resources. We're going to continue, but I think we're all going to have to stick with this together while things are pretty tough at the federal and even at the state level with the budget right now. So as we continue to send shout outs, we try to be very careful about how much we do send out, because I know your time is valuable and there are a lot of competing demands. But I would say that as we continue, again, with all of the things we're talking about today, please, just as much as you can, share the information. If we send alerts and you can make a phone call to someone in your community, your legislator, you can send an email, you can talk to the team and your leadership. Like, I think we're really in it together. So let's just keep the momentum. We've got amazing things happening. Come to the fund run, come to the symposium, April 6th, be a part of this. Join Hans on TV with inflatable colons. I'm learning myself more and more about gastric and esophageal, but really appreciate the energy. Going into a great weekend. Have a good one, everyone. And thank you so much for your enthusiasm and great work. Thanks, everybody.
Thank you. Bye.
Bye-bye.